Hi, folks. Namaskar and welcome to today's Critical Lines podcast. So, today our topic is going to be cardiac intensive care, and we have a very special guest with us, someone who is one of the most experienced in cardiac intensive care in our country. And we really thank him for his time and the amount of knowledge and experience he's going to share with us. So, Dr. Vivek Gupta, as many of you would know, is president of the ECMO Society of India, and he's a consultant in cardiac anesthesia and intensive care and ECMO physician at the Anand Medical College and Hospital Hero DMC Heart Institute, Ludhiana, and very remarkably, Chairman Research and Ethics Committee SWAC, also, which is a Southeast Asian organization, if I'm not mistaken. So, with that, the first question will be regarding mechanical circulatory support device, sir. At what point in a patient who's got compromised cardiac function, mostly we use in cardiogenic shock as of now in our setting, so at what point in his course of this deteriorating cardiac function would you like to use this device, and which type of device?
Thank you, Dr. Tapesh, for a kind introduction. And thank you for this opportunity as well. Basically, if we talk in terms of using a mechanical circulatory device in a setting of acute cardiogenic shock, so that depends because initially we try to stabilize these patients with a medical management. And when this medical management starts failing and patient starts developing the signs of hypoperfusion, that's the time to think of supporting it with the various category of mechanical circulatory device. So it all depends. What's the reversibility? Whether you are able to achieve revascularization, or you are planning to get a revascularization in coming time, or what exactly is the support is required, and what is the primary cause of this cardiogenic shock? Whether it's the mechanical issues like we see in cases of ventricular septal rupture, in cases of acute MI, or patient has developed the acute mitral regurgitation. So in those situations, things will be a bit different because you go for the early surgery and you can support with a different category of the circulatory devices, and all depends at what stages. So if I talk and in terms of choosing a device, so the first and foremost thing is always that we do an initial assessment. We look at what's the basic of the hemodynamics, what's the mean arterial pressure. So even if with the vasopressors and inotropes, we are not able to maintain the good mean arterial pressure, say just 65 or above it, our cardiac index is decreasing, patients is showing the signs of hypoperfusion, like the peripheries are cold, urine output is decreasing over a period of time, cold clammy skin, and patient is having a mentation is compromised. In the initial phases, patient may be irritable. In the late phases, he'll become drowsier. You assess the blood gases, there is a worsening metabolic acidosis, and lactates are rising. So these are the signs which we quickly pick, and you choose these patients for the mechanical circulatory support. So there are objective criteria as well besides these clinical judgments, because including when we incorporate all this, and the recent addition is the SKY classification, where with the SKY A, B, C, usually it's up to the with the medical management we can manage these patients. But if the patient is reaching to the level of D or the early late C, then possibly they are the candidate for the mechanical circulatory support. The various mechanical circulatory support, and if the patient is reaching to a category E, then possibly it's a CPR situation where you don't have any option, and quickly putting a patient on ECMO, VA ECMO will be a life-saving in those situations. So the various category of mechanical circulatory device we have, the basic one, what we for we are using since ages is the intra-aortic balloon pump. So if the patient is having some mechanical complications, then probably this device is wonderful. Our patient is having a low cardiac output state, though the shock trial has shown no mortality benefit. But with our clinical experience, we can say we are in India, we are using almost every center is using IABP and with a successful good results in the cases of acute MI or acute cardiogenic shock. The other short-term mechanical circulatory device, then comes the question in the emergency situation, what you can use? It's the VECMO is a good option because it's not only supports the heart but supports the other organ perfusion as well, which is a big concern that you should support these patients prior to the other organs have started the failing is has set in. So you use this device. This will help you to improve the cardiac output and support the other organ as well. The other can be a impella that just supports the cardiac output, but definitely it is going to be, as you progress, it becomes more and more invasive supported devices. But yes, you can maintain the cardiac output, but you can't keep this device for a very long time because it is associated with a lot of complication. So ECMO probably in between for a short-term circulatory support can be a good option, but yes, it can be escalated to any kinds of LVAD or other supports because if a patient is requiring the mechanical circulatory support for a long time, then probably a LVAD can be a good option. But one should always remember that if it is associated with the RV dysfunction or there's a biventricular dysfunction, then possibly you have to use the circulatory support devices judiciously because you need to support the right heart as well. I think Dr. Tapesh, I have covered
Yeah,
almost.
wonderful, sir. Thank you so much. The next thing we would like to discuss is the Forster classification, which I think every intensivist should know. So this Forster classification is for acute decompensated heart failure. So, sir, can you outline it and why is it important for the practicing intensivist?
Uh, Great. Your question selection is really superb, Dr.
Thank
Tapesh.
you, sir. Thank you.
Basically, this classification basically depends upon the hemodynamics because when we, as an intensivist, we are coming across with these patients, and the coming season is a very commonly we come across with the acute decompensated heart failure, a patient who is having a severe LV dysfunction, ischemic cardiomyopathy, a dilated cardiomyopathy, and they come with suddenly with a shortness of breath and when you look at the saturation it is 85 80. They increased work of breathing, they are sweating, tachycardic, and you do blood gases, it's a PO2 is very low and they are deteriorating, lactates are 2 3 that's increasing. And if you don't address these things immediately, then possibly over a period of time they keep deteriorating and ultimately they collapse and the outcome becomes very, very poor. So, subjectively, we can always assess these patients, but definitely having an objective criteria is always superior in medicine and especially in the intensive care unit. Because if you know that these are the objective criteria to assess or to identify a patient, probably a selection of drugs, choosing a right therapy can be a good strategy in those situations. So if we classify, we divide it into the four basically functional classification. The first subset is the most stable patients who are warm and dry. Warm and dry, when I say it means their peripheries are warm. It means they are not in the shock and they are dry. So they don't have much of the issue that there's a fluid shift is there and patient is tachypneic. You will not find any much of the symptoms. So this is the most simple case situation where you can simply manage these patients with the medications, readjust their medication, and it will send them home. Usually not a problem. The second category of the patients, they are warm, still they have a good cardiac output, but they are wet. So they will show some tachypnea, but not much. But they will keep complaining, I am having a tachypnea in between, I have shortness of breath. If you look at their cardiac output, usually cardiac output is above 2.2. And again, these patients have the pulmonary congestion, but their perfusion is pretty good. So in those situations, you just need to adjust or add some diuretics in these situations and vasodilators, and usually they respond very well. The third and fourth category. are really challenging. And third, when I say it means they are cold, it means they are going in the low cardiac output and they are wet also. That means they have the congestion and beyond, basically, it's a beyond pulmonary congestion. So they are congested and they are a high category risk group. That means they are going to cause um, problem in those situations that they will be tachypnic, they will have a fluid overload, and you might need to do interventions to remove the fluid. You may need to give a diuretic challenge. Infusions may be required. You need to support them the BiPAP. And as early you do intervention, it is better. And the before this, the previous category, if I say the third category, that's a cold and dry. So they are in the low cardiac output, but still they don't have a fluid overload. Means back pressure changes are not so much that they will have their fluid shift will be there. So still they are in the comfortable position. But yes, if you improve the cardiac output, then possibly they don't deteriorate further. And you use inotropic support in this situation where you try to improve the cardiac output. That prevents the organ perfusion or the affect start of prevents the damage to the other organ, especially the kidney, and in this situation that they will not have a drop in the urine output. So adding inotrope will be sufficient in the category 3. And category 4, which is the definitely a big challenge for the intensivist, there you have to be very, very cautious because these patients deteriorate very rapidly.
Thank you, Sue. Thank you. So, friends, there is a you have to classify into warm or cold and wet and dry. And along from this, you get four subclasses. And once you classify, you understand the hemodynamics and thereby your treatment. So that is the most important thing. Very nicely put, sir. Thank you. Moving on to the next question, sir, about my acute myocardial infarction, which is the bread and butter, or let's say the staple thing for cardiac intensive care. Everybody has some idea about the diagnosis, but there's a very specific diagnostic criteria for acute myocardial infarction. I think everybody should know that, sir. So if you can
Yeah.
just do that.
So when we say acute myocardial infarction, that means ECG, one of the best marker, predictor, or identifier, you can say. The patient will be presenting with the various complaints. It can be pain, perspiration, pallor, or they have some discomfort, and ultimately they reach to you. And the first thing comes in our mind that do an ECG. So if we talk in terms of specificity, the specificity of the ECG is very, very high. But if we talk in terms of sensitivity, probably it is not as high as for the other investigation which we can do. So we make a combination of investigation. If you have a ST elevation device, there is no problem. You see that there is a ST elevation, two or more contiguous leads, more than 2 millimeter in the anterior leads and more than 1 millimeter in the other leads, the suggest leads and other leads. So you quickly identify. When I say contiguous, means for inferior, it's a 2, 3 and AVF. For anterior, V3, V4, lateral V5 and V6. And besides this, if you don't have ST elevation, that means it can be either the anistemi or it can be unstable angina. So how you can differentiate? For differentiating it, you need to do some cardiac biomarkers. And the most common is the group is the troponin. When we say troponin, it can be troponin I and troponin T. They are pretty specific and sensitive. And in the early phases of acute MI, troponin T becomes positive within few hours. So if the patient has presented, you can do troponin T, you can do a qualitative, or you can do a immediately, and definitely you do quantitative that will tell you the how severe the injury is. So, and besides this, you can do a CPKMB, you can do other LDH is also one of the marker, but CPKMB and the LDH is not as good as the troponin T. So immediately you do. Besides this, you confirm your diagnosis with the use of echocardiography. You do a echo, 2D echo that will tell you the regional wall motion of the mallet in the area, besides telling you about the mechanical complication. So it is simply, you can say, this ST elevation MI, non-ST elevation MI, and unstable angina. You can differentiate easily by looking at the ECG. If there is ST elevation, this is ST elevation MI. If it is the for differentiating the non-STEMI and unstable angina, you look at the troponin T. If trop T positive, that means it's anastemy. If there is no marker has increased, it means it's a unstable angina. And definitely you do echocardiography and other tests to confirm it. These are the diagnostic tests. Besides this, definitely you have to send other investigation like complete blood counts and other tests, renal functions to evaluate your patient. But for diagnostic purpose, these are sufficient.
Yes, thank you, sir. So the troponin is very important, and along with that, there should be some other diagnostic criteria. Thank you very much, sir. So moving on to something known as vasopressor score, which we read about in textbooks and which is important for the younger people from examination, etc. Also, and maybe for us also to quantify the degree of vasopressor score. So what is this vasopressor score, and is it really relevant when you're managing?
Yeah, basically, in medicine, we always try to make an objective criteria because when we say we have patients on two vasopressors, three vasopressors, four vasopressors, like this, these are the common terminology we use. What is the dose of dopamine? The criteria may be different in different organization for preparation of the dopamine, or not dobutamine, norepinephrine, so for every vasopressors and every inotropes. So it was just a method because when you do a research at that time, probably you can do an objective analysis that how what was the degree of use of the vasopressors in these patients. That will show tell you that how much was the how bad was the shock was. So this was just a method. You calculate, you make a calculation that for a dopamine and dobutamine, whatever dose is there, you just keep adding it. Then you, for norepinephrine and epinephrine, whatever the dose is there, you multiply it with the 100. And for a milrinone, you add with a 1000. And for vasopressin, because vasopressin is in the unit dose, so you multiply with 10,000. And when you keep adding all these numbers, that will give you an idea about the vasoactive inotropic score. So that's one way, but it has its own pitfall. And besides academic purpose, probably it will not have much of the value because the two pitfalls, major pitfalls, one, it does not include all available vasopressors so far. And second, it is all has been done for analysis purpose. There is no strong scientific evidence for adding these 1000 or 100 or these numbers. These are very arbitrary numbers. So um, it for the purpose of simplicity. So yes, for academic purpose, it has a good value so that you can understand that how um, severe the shock is.
Thank you, sir. Then moving on to a more objective question, amiadarone, which is the troubleshooter for the cardiac intensivist in the ICU, used for both ventricular tachycardia and supraventricular. So, sir, what is the efficacy in these ventricular and supraventricular for treating?
Yeah, so let's take one by one. When we say ventricular tachycardia, so probably if you talk India, we don't have a procainamide so far, and we are left with only this drug as amidaron or zalocard for addressing these kinds of a refractory shock, refractory arrhythmias. So amidaron has a good efficacy in cases of acute ventricular arrhythmia, especially which is having a ventricular fibrillation, which are refractory to other management. This is a wonderful drug in those situations. But if we talk about the monomorphic ventricular tachycardia, then possibly it has not as efficacious as the procainamide is, and which has been proven in the different trials, alive trial and arrest trial, that the procainamide is superior to it. But definitely, if we say as compared to the Zalocard, which is available in our country, so efficacy of the amiodarone is much higher in those situations when it is being used in both the situation, whether we say um, ventricular arrhythmia, which is causing a hemodynamic compromise, or monomorphic ventricular arrhythmias, tachycardia, which is a stable one. So in those situations, if we talk in terms of supraventricular tachycardia, again, this drug has a significant role. Though few of the study has not shown a beneficial effect with the amidaron alone, but they have proven it as a combination that if we use it with the beta blocker, then beta blocker alone and a combination of beta blocker and amiadarone. So in those situations, amiadarone has shown a combination of the therapy has shown a higher efficacy of terminating and as a maintenance dose. So definitely this drug has a role. However, it has its own complications and it has a pro-arrhythmic potential as well, which we should always keep in mind whenever we are using amidaparone. If we talk in terms of doses, when we say a life-threatening ventricular arrhythmia, like a cardiac arrest situation when we are dealing with the pulseless ventricular tachycardia or ventricular fibrillation, the dose of amidaparone is a 300 milligram bolus, followed by any subsequent doses will be 150 milligram. However, when we are dealing with the supraventricular tachycardia or other termination of any acute arrhythmias of non-life-threatening situation, we use a 150 milligram over 10 minutes. And then we start with the infusion, that's 1 milligram per minute for next 8 hours. And for next 16 hours, we continue the infusion at a 0.5 milligram per minute for next 16 hours. So we give it 24 hour and then we cover it with the amidaparone tablet if condition permits. And then we can switch over to the oral medication.
Yeah, thank you, sir. And this 300 milligram bolus is only very specific for this particular condition, pulseless ventricular tachycardia going into cardiac arrest. Otherwise, don't give it as 300 milligram bolus. Please be
Yeah.
careful. So, sir, then just carrying that forward, ventricular tachycardia discussion, we have torsades de Pointes, a very interesting arrhythmia. So, how do we recognize it and how do we manage it and when do we get it?
If we say torsades, it's nothing but actually a polymorphic ventricular tachycardia. The only differentiation with the polymorphic ventricular tachycardia and torsades is you can identify where complexes, multiple complexes in one go, you can identify here in the polymorphic ventricular tachycardia in a specific site of torsades, where when you look at the isoelectric line, you will find that the certain complexes in between, they will have the similar up and down movement. And basically, most of the time, if we classify it, torsades, it is a congenital, usually very well stable patients and usually not causing a problem. But acquired polymorphic ventricular tachycardia, that's the torsades, is really a challenge because it is associated with the prolonged QTC, and this can be because of multiple drugs or multiple electrolyte imbalances. Drugs, any of the antiarrhythmic drugs that can cause a prolongation of QTC and they can lead to psychotic drugs or anti these antimicrobials, some of the antimicrobials like antifungals, they all can cause a prolongation of QTC and they can lead to a torsade situation. Besides this, hypomagnesemia, hypokalemia, or these electrolyte imbalances can also cause a torsades. So the focus should be first thing that whenever you are managing, you should be able to prevent the torsades situation of a torsades, because where the moment you see that the any on ECG, you are finding that the QTC is prolonged, it is above 480 milliseconds, or even you can use the simple ECG criteria that you look at the complete ventricular depolarization and repolarization, that you take the length of that, you draw a similar length line next to it, and if the next QRS complex is falling inside this, that means QTC is prolonged. That's a very simple way of identifying the prolongation of QTC. So in those situations, you look at your treatment chart that any offended drug should be stopped immediately. You look at your investigations, what's the potassium, what's the magnesium, or other electrolytes, which can calcium, which all can lead to a precipitation. So basically, what happens when there is a prolonged QTC, there is a high risk of RNT phenomena. So any topics which has come during a T wave can lead to, because this leads to a prolongation of refractory period, and that any ventricular arrhythmia can precipitate the torsades. So once the torsade, it usually, when we say polymorphic ventricular tachycardia, in initial phases, it seems that they may be stable. but if not hemodynamically, but if not treated very aggressively in those situations, then there is a high possibility that they degenerate and ultimately they lead to a ventricular fibrillation. So it is always a dictum to say when you have a polymorphic ventricular tachycardia, it should be treated like a ventricular fibrillation very aggressively. The only thing here, correction of electrolyte recovers the condition very quickly. So giving magnesium, though few of the study has not proven benefit, but is still magnesium is one of the drug which should be administered, which is helpful to terminating these torsades. And you correct the other electrolytes, you remove the all offending drug, and if the patient is having a hemodynamic instability, is deteriorating rapidly, then a cardioversion immediately is warranted.
Thank you, sir, for detailed answer. I think it's very, very important torsade pointers for the intensivist, especially the younger people who are at the bedside all the time. And it's very treatable also. I mean, it is treatable if you get it right. So just a final question quickly now. We're finishing the CPO, cardiac power output. So how do you calculate it and where do you use it?
Basically, when we talk about CPO, it is basically what is happening. The heart is pumping the blood. So when it is pumping, it is um, having some energy utilization of some energy. So this for last 2 decades, I'll say, lot of interest has developed in the CPOs, cardiac power output. That if this is less than zero point 0.6, it is associated with a very poor outcome. If it is above zero point 0.6 or zero point 0.8 or zero point 0.7, it is associated with a good outcome. This was first looked in the shock trial. They did one separate arm analysis of the data, and what they found, the cases where the CPU was more than zero point 0.6, the survival was much better as compared to when the CPU was less than zero point 0.6. So how do we calculate it actually? In the normal course, what happens as an intensivist, we look at the mean arterial pressure. For everything, we look at the mean arterial pressure and we assume that this is actually maintaining a good perfusion to the all organs, including the coronaries, or it is going to give a better perfusion. But this may not be the case in all the situations because just improving the mean arterial pressure will not signify much. It because you have to understand this can be at the cost of systemic vascular resistance as well. So in those situations, when the SVR is increasing, it means you are keeping increasing your afterload and you are keep pushing the vasopressors to maintain the mean arterial pressure that will actually further compromise the organ perfusion. So if we understand this concept, using CPO will be very, very helpful. So if we say how do we calculate it, you just multiply mean arterial pressure with cardiac output and divide it with the 451. This 451 is basically a figure when we take a normal blood pressure as a systolic diastolic, we look at the mean pressure. So that comes whatever. If we take a blood pressure is 120/80, we take a SVR, we take a mean CVP. So all these taken in consideration, and when we calculate, you divide this with number to convert it to watt. So this value, what zero point 0.6 comes, what we say that if it is less than 0.6, it's a 0.6 watt. And this is what you get from by dividing it with the 451 number. So it is very simple because with the echocardiography, you can always calculate cardiac output. There's no problem. In the ICU, most of the time we have the invasive artery line in place. You can calculate the cardiac output with that. You can use any other non-invasive method of, though that may not be as good as with the you do with the echocardiography or if you do a cardiac output to the using SWAN. But at least you will get a good idea about the cardiac power output. So this probably we should start developing our habit to use in the intensive care unit to assess the patients who are in the cardiac shock. But one thing we should remember, this is not for the patient who are in the chronic patients. This is basically useful in the patients who are having a acute cardiac shock. And there you can calculate and probably you can tailor your therapy and you can even start prognosticating on the basis of this. So that will be.
Thank you, sir. Thank you so much. That was the last question. Really very nice words, straight from a hearty experience, if I may say. There's a lot of experience in that. Thank you so much. So, dear
Thank you.
friends, as you know, science, medical science is like a song, and it has two chords: science and art. So, saving the heart is science, but sustaining it is art. So, we have to combine both science and art, not only in cardiology, in cardiac intensive care, but in the intensive care unit for all the things. Okay, sir. Thanks a lot. Thank you very much.
Thank you very much. Thank you, Doctor.
Thank you, dear audience, dear friends, dear colleagues. Bye bye. Good night. See you again on 16th. Bye bye.